Symposium, Old Problems, New Opportunities. Despite the fact that COPD is a chronic disease, early detection and timely treatment are needed to achieve clinical results. The discussion of clinical recommendations, Goal 2023, the broncho lung pathology during pandemic, the importance of three-component therapy of COPD will be discussed at the symposium. Hall number 1. Hall number 2, dyslipidemia in young patients. When and how to examine young people for dyslipidemia. When and how to see the changes in the lipid profile in young patients. What should we focus on in treating dyslipidemia? Answers to these questions will be provided during the symposium. Hall number 2, 9:30 Moscow time. Already solutions for difficult patients with arterial hypertension. Arterial hypertension is an important problem of modern medicine. Experts of the symposium will analyze the world experience and will share their practical instruments to solve complex clinical questions. When we're talking about antihypertensive therapy, we'll also pay attention to management of patients who did not achieve the targeted arterial blood pressure figures. Hall number 3. Hall number 4, increased uric acid, how to examine symposium. The multidisciplinary approach to treating patients, how to make a differential diagnosis when the uric acid is elevated, what is the golden standards in managing patients with gout in 2023. Uric acid could be the first marker. The leading experts of the Eurasian Association of Therapy, Hall number 4. Good morning, distinguished colleagues. I'm glad to welcome you at our symposium. Today we have a nice team, therapists, rheumatologists, nephrologists, and we'll be discussing issues related to a very important problem as far as internal medicine is concerned, namely increased uric acid. How often does this happen? How to examine the patient? How to detect such patients depending on the risk of hyperuricemia? So we'll try to provide answers to all these questions. It's a great pleasure for me to give the floor to the first speaker, a rheumatologist, Dr. Roman Bashkinov, who will be talking on asymptomatic hyperuricemia, to treat or not to treat. This is a very interesting topic indeed. Roman, the floor is yours. Good afternoon, Natalia. Good afternoon, dear colleagues. Let me open our round table by the discussion of the subject, asymptomatic hyperuricemia. Asymptomatic hyperuricemia is very widespread. Well, that's the elevated level of uric acid, more than 420 micromoles for men. And in the Russian Federation, the incidence rate is 17%. Also, in island countries, the indicator is even higher. And in the US, for example, is every 5th adult has hyperuricemia. Asymptomatic hyperuricemia is the main risk factor of such a disease as gout. Nevertheless, not all patients who have elevated uric acid can have the articular syndrome. Here you can see the observation study, a 5-year study that shows that on average, only every 5th patient who has a hyperuricemia can progress to gout. As you can see here, the tallest bar is 49%, but primarily these are male patients with higher risk factors, and the level of uric acid is more than 600 micromole per liter. You can see the difference can be very significant. And for example, as for the incidence rate in Russia, well, it can be 16.8. As for gout, it can be different. And of course, we can see that the problem is underestimated by different specialists. It is well known that hyperuricemia is linked to cardiovascular diseases, kidney disease, poor metabolism, and cardiovascular diseases and general mortality. Well, you can see there have been experimental studies, observational studies that have proven that, clinical trials, and at the same time, the randomized clinical trials show the positive impact of the reduction of the level of uric acid on the progression of these conditions. Some studies did not show the efficacy of this therapy, but nevertheless, it should be noted that those studies that have had a positive effect are more in multitude, and this should be taken into consideration. Well, hyperuricemia can lead to different comorbid conditions, and this slide shows one of the studies, almost 6,000 people with concomitant diseases in Japan. The diagram shows that hyperuricemia was linked to the incident rate of different diseases such as arterial hypertension, dyslipidemia, chronic kidney disease, and obesity. The dose-dependent correlation of uric acid was very well manifested. You can see if the uric acid is increased, well, the incidence rate of these chronic diseases is also increased. Well, the Mechnikov University, under the auspices of academician Mazurov, we are monitoring such patients. We have a big registry of patients, and I would like to share my data here. You can see the cohort of patients with osteoarthritis. It is well known that osteoarthritis is linked to comorbid conditions. We compared osteoarthritis patients with normal uric acid level and with increased uric acid level. And you can see there are statistically important differences in case of cardiovascular diseases and renal diseases, metabolic disorders. The higher the level of uric acid, the more such diseases occur. Also, the uric acid can have an impact on the development of comorbidities. First and foremost, kidney diseases or kidney injuries. This is associated with hyperleukemia and the development of different dysfunctions. Also, renin RAS system is activated. You can see that can also lead to hypertension and tubular interstitial fibrosis. There are two mechanisms, crystal-dependent and crystal-independent mechanisms. Well, the deposition of crystals such as SMU, and this can provoke the development of different fibrosis. On the other hand, soluble uric acid is a risk factor of endothelial dysfunction. It can lead to the development of the deficiency of synthesis of NO, and this can change the RAS system. This can lead to tubular ischemia, and there have been a lot of studies conducted on the subject. Here you can see one of them, the meta-analysis, which included more than 3 million patients with gout and asymptomatic hyperuricemia. You can see that hyperuricemia has a direct link with the significant risk of quick reduction of glomerular filtration rate. The use of urine acid reducing therapy during 1 year was associated with a significant improvement of glomerular filtration rate and proteinuria. So this is the major analysis that shows how the reduction of the uric acid level can have a positive impact on patients. Here you can see the Russian guidelines. And of course, patients are recommended to have the uric acid level monitored in this situation because the uric acid is the prognostic risk factor in case of kidney disease, and there is a link between hyperuricemia and the uric acid level. Naturally, the uric acid can be associated with kidney injury, is quite obvious. And of course, control of hyperuricemia can have a positive effect on prevention of kidney disease and on prevention of progression to more severe forms. You can see these observational studies were the foundation of Japanese guidelines for patients with hyperuricemia. You can see there are some changes in the updated guidelines. Even patients with asymptomatic hyperuricemia, the level of more than 535 micromoles per liter should be the candidate for therapy. Change in diet, therapy of chronic diseases. As for medical therapy, that's a very relevant issue, and medical therapy can be considered if the uric acid is higher than 535 micromoles per liter, and if patients have chronic conditions such as kidney diseases, arterial hypertension, heart failure, etc. And of course, here, the high level of evidence is kidney injury. In the Japanese population, there is a high risk of adverse events that can be caused by the high level of uric acid. Despite that, the Japanese recommend we start treatment as soon as possible, and also the Endocrine Academy, IDEA, consider the medical therapy in case of kidney pathology, especially when there is such conditions as kidney stones. And again, the medical therapy is recommended for patients with asymptomatic increase of the uric acid level. The uric acid can also lead to the metabolic syndrome, as you can see it here, and it will compete for reabsorption mechanisms in the nephron. And here there is a link between obesity, arterial hypertension, and the impact on these conditions can improve hyperuricemia and to the reduction of the level of uric acid. On the other hand, some major studies, including the meta-analysis, have shown a link between the increased uric acid and the non-fatty liver disease. Arterial hypertension can also have an impact on the cardiovascular system, and here there are two mechanisms of action. Well, you can see urate sodium can have an impact on it, and xanthine oxidase. And of course, the high activity of it can have an impact on the cardiovascular system. Xanthine oxidase increases its activity in case of hyperuricemia. And here it has a negative impact on RAS because it becomes more activated, the proliferation of cells and the development of the endothelial dysfunction with NO2 more activated. Here is a meta-analysis, 18 studies. Hyperuricemia is linked with a higher risk of arterial hypertension to when there is an increase of the uric acid of 1 milligram per deciliter, the odds ratio was more than 1. And this was the result of this study. This study is not alone, and you can see uric acid reducing therapy has a positive impact on patients with comorbidities. This is written into Russian and European guidelines. Not all patients with arterial hypertension should have the uric acid tested, but in most cases, this can be a very important marker of the risk of cardiovascular diseases, which should be taken into consideration when we choose therapy for this cohort of patients. Uric acid and hyperuricemia also can lead to the development of atherosclerosis. The mechanism is quite simple here, oxidative stress, and also low inflammation. Uric acid can cause gout. That's a major inflammatory process associated with the high level of production of interleukin-1 beta, interleukin-18, and in this case, the arthritis can be accompanied with the low intensive inflammation and can be accompanied by inflammatory changes and lead to the progression of atherosclerosis. Hyperuricemia and coronary heart disease, a meta-analysis, more than 341,000 people, and you can see that when the uric acid level is increased by 1 milligram per deciliter, there is an increase of death by 20%, and you can see the impact of hyperuricemia on coronary heart disease. Major studies have been conducted here, but we're still waiting the results of major trials, and All Heart is one of them. The results were published quite recently. We hoped that it would shed light on this problem because there were still white spots in this question, but unfortunately, the study did not help us solve all the problems. There are some nuances here, and first and foremost, patients were selected into the group of allopurinol and the control group. These are patients with coronary heart disease without gout in history, but the basic level of uric acid was not taken into account. In fact, it is shown here, but there are no patients with hyperuricemia, and the level of uric acid is not 350. And these patients had therapy with allopurinol, 600 milligrams per day, and we can see it's not even typical of patients with gout. There were no differences identified between the groups in terms of non-fatal MI, stroke, and death from all causes. So the patients who were on therapy did not have any differences in terms of outcome from the control group, and there were no differences in terms of adverse events. And this is one of the major problems, potential adverse events caused by allopurinol. And here we can see that adverse events were basically the same in both groups. So what conclusions can we make on the basis of the study? The administration of allopurinol for patients over 60 does not reduce the risk of cardiovascular diseases, but there is no link with hyperuricemia. The main question was not answered. How can allopurinol have impact on the outcome of patients with asymptomatic hyperuricemia? We're still waiting for further study results. And on the other hand, there are other studies showing that the frequency rate of adverse outcomes, favorable outcomes in a 5-year period on allopurinol, which inhibits xanthine oxidase, was lower than in patients who were not on the drug. This concerned patients with gout and hyperuricemia, and xanthine oxidase that has the cardiotoxic effect increases its activity in case of hyperuricemia, and we can see the positive effect of this therapy. Here is another major study, the uric acid reducing therapy and mortality of patients. We can see that at the top, we can see patients with hyperuricemia, they had more favorable outcomes. At the lower graphs, we can see that patients who were on urate reducing therapy had the lower chance of poor outcome, which proves the potential positive effect of urate reducing therapy on the cardiovascular system and on health in general. Here, there is a question that we can discuss. The threshold of uric acid, usually it's 420 micromoles per liter, but as for large studies, they have shown that the uric acid can have a negative impact on the cardiovascular system, even if the level of the uric acid is lower. This question is still under discussion. You can see that when it's 280 micromoles per liter, well, it can have an impact on coronary vascular diseases and death. Here you can see the consensus on the management of patients with asymptomatic hyperuricemia and patients with high cardiovascular risk. And you can see, so these are our data and the data of our European colleagues. These documents are being updated on a regular basis, and you can see that we should assess the uric acid level in blood serum. It is high if it's more than 360 micromoles per liter. To assess concomitant diseases in such patients and the volume of therapy, if needed, you should stop administering drugs containing uric acid. The use of diuretics should be stopped. Losartan is the drug that has the proven anti-hyperuricemic effect. Well, and losartan is the only anti-hypertensive drug, and we can also switch to alternative drugs, and statins can be used in this situation. It is not recommended to switch over to fenofibrate. You should inform the patient about the situation. We should change the diet, reduce the BMI, regular physical activity for the patient is a must here. This has a positive impact on the uric acid level. You can start with allopurinol. The starting dose is from 100 to 200 milligrams, then to titrate it to 300, 600 milligrams. The targeted level should depend on the cardiovascular risks, and we recommend you switch over to medical therapy if all other steps are inefficient. And also, when the targeted uric acid level is achieved, the patient should continue to be on drugs, and we can also use a combination therapy in this case. Dear colleagues, thank you very much for your attention. I would like to sum up and say that asymptomatic hyperuricemia is an important problem of internal medicine. Whether to treat it or not to treat is a very relevant question. Of course, we believe that it should be treated. First of all, non-medical therapy, also the impact on concomitant diseases, and of course, we should consider medical therapy if there are specific conditions such as high uric acid level, comorbidities, to mention but a few. So this question is quite clear for us. Asymptomatic hyperuricemia, it should be treated. Thank you very much. Thank you very much, Dr. Bashkirov. That was a very interesting presentation and quite profound. Yes, dear colleagues, we understand that there is no just one approach, no one particular figure regarding the level of uric acid when medical therapy should be started. And Roman gave us a very interesting overview in his presentation. Patients of high cardiovascular risk who have different cardiovascular diseases are a special group of patients. We should test their uric acid level properly and to start urate reducing therapy timely. In speaking of hypertension, patients with cardiovascular diseases, of course, dear colleagues, in clinical practice, the question is, can we administer diuretics? What kind of diuretics to the patient who has increased uric acid? And the next speaker, Dr. Trubnikova, who is a nephrologist, will try to answer this question, please. Good afternoon, dear colleagues. As it has already been mentioned, diuretics is a very well-known instrument in treating arterial hypertension. At the first stage, when we just see our patient with a specific clinical condition, well, this is a very good instrument for managing patients with chronic heart failure. And of course, it can have an impact on the subjective feelings of the patient. And you can see that there are different kinds of diuretics. Well, they can have an impact on the proximal canals. We have thiazides, we have carbar and anhydrase inhibitors such as acetazolamide. We have loop diuretics and also uric acid. And the uric acid is involved in the exchange process. During the glomerular filtration rate, there is the production of uric acid, and there is just a safe amount of deposits of uric acid in blood for exchange if the patient is healthy. As for HCTZ, well, again, you can see they can have a negative impact on the uric acid exchange. And you can see thiazides can lead to the situation when during treatment with such drugs, there can be elevated uric acid. It can have a negative impact on kidneys due to the elevated uric acid. So again, that means the higher burden on the kidney, and it's a vicious circle. Shown here, arterial hypertension develops, cardiovascular diseases, and renal ischemia, etc. At the same time, there may be a negative effect which will worsen the course of cardiovascular diseases and could lead to the exacerbation of chronic kidney disease, regardless whether there is such a condition or not. During the regulation of uric acid exchange in kidneys, you can see there are different genetic factors involved here. It should be noted in this transport system, there are transport proteins which are directly linked to the excretion of uric acid, and other drugs can be also an alternative to managing such patients and have a positive impact on the uric acid exchange. Well, you can see diuretics can cause hyperuricemia. In this case, we should cancel this class of drugs. We should figure out which patients have a stronger effect caused by diuretics and what measures should be taken to avoid this high effect, especially when we're talking about comorbid patients. The impact of diuretics on the development of gout, there were several studies conducted. You can see them in the left column of the chart. These are patients with undiagnosed cardiovascular diseases and also large cardiology studies when thiazides had an impact on elevated uric acid and exacerbation of gout. Well, we can see that there were a lot of studies conducted on this subject, and we can make conclusions that diuretics therapy should be well thought because they can lead to the exacerbation of gout. we should pay attention to the renal function, especially when we're talking about patients with cardiovascular diseases. The level of creatinine, while also estimated glomerular filtration rate should be measured, and the level of uric acid. Besides that, there are other factors contributing to the development of hyperuricemia when patients are on diuretics. That's the previous production of kidney function. Genetic factors are also quite known, but we don't have guidelines for genetic tests of such patients in order to identify those patients in whom diuretics can lead to all these negative effects and should be canceled or should not be administered. So as you can see here, more studies are needed so that we could write the results into our guidelines, especially as far as loop diuretics are concerned. Right now, for practical purposes, genetic factors cannot be used in our practice. As for the direct nephrotoxic action of thiazides, well, it can lead to apoptosis of cells of the distal tubulars. It can have an impact on interstitium, and it can lead to glomerular ischemia. Here you can see the direct nephrotoxic action. Well, you can see again how loop diuretics can lead to normoruricemia, the formation of crystals, etc. And here you can see the impact of inflammation on the renal function. Sterile stimuli of inflammation, such as ischemia, hypoxia, hyperglycemia, and hyperlipidemia, etc. And you can see there is a vicious circle formed, and you can see there may be inflammasome-dependent NLRP3 or inflammasome-independent NLRP3, such as IRI, diabetes, and other diseases. Well, and of course, here we should pay more attention to interleukin-6 and others that can have an impact on the glomerular structure. Hyperuricemia in the healthy kidney, hyperuricemia induces glomerular hypertrophy and hypertension. It can lead to afferent sclerosis and microphagal infiltration and chronic inflammation. As for the strategy of patient management with chronic kidney disease and without chronic kidney disease, it is necessary to determine whether the disease exists or not before the start of the therapy. We should assess the hydration status. Of course, we should determine the uric acid level before the start of the therapy. Also, the therapy in this case should be conducted using the minimal effective doses of diuretics. And also, we can administer the therapy using other classes of drugs, such as ARB, SGLT2 inhibitors, or statins, or fibrates. And of course, we must minimize the level of uric acid, and also non-medical therapy can be quite possible here, which was mentioned in the previous presentation. In this case, we can achieve much better results if we use this particular algorithm of patient management. This can have a positive impact on the reduction of inflammation, and we can achieve much better results, especially those patients who have different chronic kidney diseases. Well, we must remember that non-medical correction of our patients, such as change of diet, well, physical exercises can be of great importance for our patients, and we must depending on the set of comorbid conditions to exercise control over therapy to make this therapy more effective. We must control blood pressure and other targeted indicators, such as uric acid level, so that we could have the stable indicators, including the creatinine level, glomerular filtration rate, and this may have a positive effect on chronic kidney disease. We can also add allopurinol to diuretics, and again, this is the major strategy of patient management. We can add allopurinol to reduce the uric acid level. And of course, as for diuretics, we must look at the reduction of uric acid level if the effect is positive after some time of treatment with diuretics. But also, we can use diuretics therapy, but in this case, the dose should be twice as less. If we see that the uric acid level increases again, we can consider the addition of allopurinol. And again, the doses should be corrected, especially for patients with cardiovascular diseases. So this is a big question for us. And remember also the issue of polypharmacy can be of great importance here. Just see what other drugs the patient is on, if there is any nephrotoxicity, etc. Thank you very much. Thank you very much, Ms. Trubnikova. I think that was a very important presentation, colleagues. Now, just imagine the situation which occurs rather often in our clinical practice when a cardiologist, like me, for example, turns to a nephrologist with the question, can we recommend diuretics, like loop diuretics, because the patient has anemia, hypertension, heart failure with the preserved ejection fraction. Marina, once again, what recommendations would you give to cardiologists? Thiazide-like diuretics should be cancelled, well, or not? Or we can use loop diuretics. Well, I can ask a nephrologist as a cardiologist. A patient with hyperuricemia needs diuretics therapy. What is your opinion? What should be done in this clinical situation? Well, in this situation, regardless of the glomerular filtration rate, when we're talking about hyperuricemia, you should start with loop diuretics first and foremost. But depending on the heart failure, we can consider other drugs such as varospiron if the cardiovascular system allows it, and practically each of them can be a potential risk factor. Loop diuretics, as far as this effect is concerned, well, the risk is lower, especially in terms of exacerbation. So I would consider loop diuretics depending on the clinical situation of a particular patient. Well, we should also look at the speed of the development of such an effect. When we're talking about cardiovascular diseases, the effect we can have in terms of elevated uric acid due to loop diuretics will lead to a lower development of this condition as compared without the use of diuretics. Thank you very much. So you recommend loop diuretics. I agree with you. Yes, there are situations when we cannot get rid of diuretics. And the most important thing is the control of the uric acid level and glomerular filtration rate. Thank you very much, Marina. And dear colleagues, we have another question for you. Marina, another drug, another class of drugs. We have talked a lot about thiazides, thiazide-like diuretics. We have another presentation on, well, anyway, we'll answer this question later, but in the chat, there is a question for you. And now I'll give the floor to the next presenter, and then we will answer all your questions, dear colleagues. Evgeny Melnikov is our next speaker, differential diagnosis with an increase in the level of the uric acid. Please. Good afternoon, dear colleagues. For us, it's important, especially in the context of this presentation, it's important not why the uric acid level increases, but the number of different conditions. What conditions can lead to an increase in the uric acid level? That's very important. I would like to go into detail, regardless gout or urate nephropathy, prolitease, etc., because everyone knows that hyperuricemia is associated with 3 specific diseases. I wouldn't like to go into detail as far as the discussion on what came first, hyperuricemia that led to the development of other conditions, comorbid conditions such as coronary heart disease, chronic kidney disease, or vice versa. Hyperuricemia occurred as a result of these diseases. Both theories are true. Maybe we should combine them into one. For us, what is important to make the differential diagnosis and to understand how often we can detect such conditions, especially in conditions when there is a wide range of different diseases that can lead to such conditions. The first reason is hereditary reason, Lersch-Nyheim syndrome. As you can see it here, the deficiency of hypoxanthine guanine phosphorybasyltransferase. This can lead to mental deficiency. This can lead to aggressive behavior, hyperkinesis. Well, this disease requires a differential diagnosis due to the different neurological symptoms. Another condition which is linked to chromosomes is the elevated activity of phosphorybasyl pyrophosphatase synthase. Here, there can be light course of the disease and severe course of the disease. Like the disease can develop in the adolescent age or in older age. There may be hyperuricemia or ataxia, and there may be other neurological complications. This occurs in 70% of cases when these diseases are manifesting themselves, when the patient has this particular condition. And in this case, we can have patients with ataxia and mental disability. Also, another reason is the accumulation disease of glucogen type 1, 3, 5, and 7. That's an autosomal condition accompanied by short for gestational age, also progression of chronic kidney disease. For us, it is important to pay attention to hereditary reasons which are associated with the reduction of excretion of uric acid. This happens when we have autosomal dominant tubular interstitial kidney disease, also Bartter syndrome, and polycystic kidney disease. Autosomal dominant polycystic kidney disease usually has a debut in older age, and the outcomes are very unfavorable, usually resulting in death due to severe kidney injury. And polycystic kidney disease, since it is autosomal dominant, can lead to progression of this disease, not just in kidneys, but in lungs and other organs. Moreover, here you can see some of the genes participating in the excretion of uric acid, both renal and abdominal. When there are some polymorphisms of such genes, there are problems with the excretion of this metabolite. This slide shows the metabolism of uric acid and its transport in renal tubula. We can see urate 1, urate 9, and GLUT9A. They can reabsorb uric acid, or they can be blocked completely or partially, leading to the removal of uric acid, and this is the mode of action of glucosiduric drugs. It is important to say that the metabolic syndrome is an important factor in the development of uric acid elevation. Obesity, for example, and insulin resistance can lead to the activation of transport structures such as urate 1 and others which reabsorb uric acid into the blood, leading to hyperuricemia. The first slide actually stated that hyperuricemia occurs when the indicator is more than 360 for women, but there is one protector which has the suppression effect, xanthine oxidase, XO, and xanthine oxidase increases the potential of excretion of uric acid. When the balance is broken, well, then this indicator is 420 in women. Also, there is a wide range of comorbid conditions that can lead to hyperuricemia, such as chronic kidney disease, for example, and we must remember that it's not just the excretion problem. It can be also increased production and, of course, lead nephropathy and any other kinds of poisoning that can block the breathing system, blocking the renal cells, thus creating problems with excretion of uric acid. Preeclampsia is another factor. There are studies showing that women during pregnancy can have an increase in uric acid. That's a sign that the woman has preeclampsia. Different kinds of cancer oncology, cancer cells proliferate quickly in this case, and it's more difficult to differentiate them. They usually have a shorter life cycle, and as a result of lysis under the influence of treatment or under the influence of their own life cycle, they collapse and they have a lot of nucleides, and after the cycle of reaction, this leads to an increase of uric acid level. Diuretics are the drugs which are used quite often, beta blockers, and also there are drugs that can be used in case of chronic kidney disease and in case of conditions which have an impact on renal tissue, such as autoimmune diseases or focal segmental diseases. Well, after organ transplantation, so such drugs are very widely used, such as cyclosporin, tacrolimus, beta blockers, well, ethambutol, pyrazinamide, levodopa, and as for tuberculosis, for example, TB can lead to increased urate level, and therapy with ethambutol, pyrazinamide, can also lead to hyperuricemia. Levodopa is a drug used to treat Parkinson's disease. It also blocks urate transport, and also the use of laxatives is another important problem. This condition can be included in the criteria of diagnosis, and of course, this is one of the primary reasons of death from psychiatric diseases. Myeloproliferative diseases, I wouldn't go into detail because the next presentation will be devoted to this, but the most important thing is that we can see elevated uric acid in blood. And for example, in case of chronic myeloleucosis, such as, anemia, splenomegaly, fatigue, etc., AML, that's a very serious condition that can cover other conditions depending on genetic markers. Anemia, leukopenia, leukocytosis, depending on the situation, thrombocytopenia, splenohepatomegaly, skin itch, malaise, and Philadelphia negative diseases, usually associated with JAK2, etc. That's true polycythemia, and idiopathic myeloproliferative disease, thrombosis, etc. Lymphoproliferative diseases usually do not have some specific symptoms. We can only make a guess when there is some particular symptoms such as malaise, chest compression, cough, catheter and splenomegaly, lymphadenopathy. There are also B symptoms, which are not very specific. Nevertheless, fever over 38 degrees Celsius for a long time. Night sweats, which are quite profuse when you change bed sheets twice a day. Also, the loss of body mass more than by 10% during 6 months. And I would like also to say a few words about the myeloma disease, which has a wide range of clinical manifestations, non-specific manifestations such as malaise, vascular problems such as renal phenomenon, bleeding, hemorrhage, etc., pain, compression, fractures, chronic and bacterial infection. So you can see a lot of monoglobulin G, which is not active, but there is a high production. We can see proteinuria in urine. It can be quite manifested, 10, 20 grams per day. But at the same time, the protein blood level is quite normal. Nevertheless, we can see that this can cause some shock at the very beginning. Anemia, leukocyte thrombocytopenia, hypercalcemia, progression of chronic kidney disease, which exacerbates the situation because we have elevated uric acid. It goes up in case of lymphoproliferative diseases because of the large number of cells and their lysis. And another pathognomonic syndrome is the erythrocyte level increase. Hemolytic anemia, again, here we can see that there are mechanic risk factors such as valve prosthesis, when there are biological reasons such as the intake of drugs, while also poisoning, and immunohemolytic anemias are quite rare. They can have different manifestations such as thrombosis, especially when we're talking about paroxysmal night hemoglobinuria. Psoriasis. Well, as for psoriasis, this disease is also marked by the proliferation of skin cellular structures with minor differentiation, with an increased level of uric acid. Psoriasis can be accompanied by arthritis, can be accompanied by monoarthritis. And of course, here the differential diagnosis must be carried out between arthritis and gout. This is one of the most difficult questions because patient with arthritis can be very comorbid, and standard treatment is limited. So here there is a need to make a differential diagnosis. Also, I'd like to say a few words about myopathy, especially in the era of COVID-19 pandemic, where we can see post-infection conditions such as Coxsackie virus, other bacteria, well, inflammatory myopathy, and the patient has complaints about malaise, about weakness in proximal muscles of upper and lower extremities. Patients cannot make specific movements such as open a door with a key, cannot open a bottle, or a young girl cannot hold her baby because she becomes weaker and weaker every night. And sometimes, well, her gait can change, and also there might be skin rash such as hyperkeratosis, etc. And also myopathy can be accompanied by other factors. Again, you can see we should pay attention to LD levels, etc. And rhabdomyolysis can be one of such manifestations. So the number of conditions that can lead to increased uric acid is quite a few. So we must just make a decision if it's hyperproduction, hyper-excretion of uric acid. Both mechanisms in this case can prevail, and one exacerbates the other. So if we exclude the most widespread reasons for development of hyperuricemia, we should start the diagnostic search because hyperuricemia can be the first marker of serious diseases, which will be mentioned in the next presentation. Thank you for your attention. Thank you, Evgeny. Indeed, dear colleagues, in our routine clinical practice, sometimes we don't even think about all those reasons that can lead to increased uric acid. Allow me to move to my presentation. While my colleagues are reading the questions, I think at the end of the symposium, we'll have an interesting discussion because there are lots of interesting questions. Thanks for your questions. Thanks for your interest in the problem of hyperuricemia. My presentation is called Leukemia and Lymphoma. Could uric acid be the first marker? It's a very serious problem, and the uric acid can be a marker, sometimes even the first marker we should pay attention to in order to diagnose these very serious diseases. First of all, I'd like to say a few words about what lymphoma is. It's a malignant tumor of the cellular immunity when lymphocytes increase to gigantic sizes. They split and affect the lymphatic system. We can see the clinical manifestations, an increase in lymph nodes, and also the damage to bones. Lymphomas can be divided into Hodgkin and non-Hodgkin lymphomas. Hodgkin lymphoma is lymphogranulomatosis, which is characterized by the damage to B lymphocytes. Those cells, as you can see here, Reed-Berezovsky-Sternberg cells, which are detected in patients, are the diagnostic marker of Hodgkin lymphomas. Well, this disease is characterized by the aggressive course, but can be treated quite well. The second large group are non-Hodgkin lymphoma, when not just B, but also T lymphocytes are affected. You can see the classification of non-Hodgkin lymphomas. There are lots of them. It's not my goal to give you a classification of each of these diseases, but I would like just to say a few words about diffused B-cell non-Hodgkin lymphoma, which occurs rather often in clinical practice. And today I would like to talk more about this disease in detail. Another important classification is the classification in terms of pathogenesis. All lymphomas can be aggressive, which can develop quickly with manifested symptoms extranodal. When the internal organs are affected right away rather than lymph nodes, and it's difficult to diagnose such conditions. And indolent, which can progress but very slowly, sometimes doesn't require therapy. So as for diffused B-cell lymphoma, DBCL, it has extranodal infiltration with large B lymphocytes. And lymphoma and hyperuricemia, what is the link between them? My colleagues have already said that there are different reasons that can lead to increased uric acid. Evgeny showed in his presentation those mechanisms that lead to increased uric acid, and uric acid is the end product of metabolism. And when there is increased uric acid level, there may be two reasons leading to this. Well, increased production or problems with excretion of uric acid. I agree with my colleagues that in most cases, patients can have both reasons involved, and our goal is to identify this condition and, of course, to start treatment of this category of patients. So, dear colleagues, uric acid is the end product of metabolism of purines. We all know that its amount reflects the turnover of nucleotide acids in cell elements. Patients with solid cancer can have elevated uric acid, and this can be the marker of the disease, because in this case, you can see there are interesting studies showing how the original or basic uric acid level can allow us to make a prognosis on the outcome of treatment of patients with B cell lymphoma. The lower the uric acid level is, the better the prognosis for such patients is. Usually we analyze two indicators: overall survival and progression-free survival. And you can see that both indicators depend on the basic level of uric acid in such patients. That is why, if we look at our standard Russian patient with a metabolic syndrome, a patient who had a high level of hyperglycemia, and there is a lymphoproliferative disease, in this case, the uric acid will be elevated quite significantly, and this will be associated with the worse prognosis. Why the uric acid is elevated? It is related to TLS, tumor lysis syndrome. And you can see this is a very progressive hematological change, especially when we're talking about malignant neoplasms. We can talk about patients who had treatment or who had stereotaxic therapy or no treatment at all. So in this case, if we have elevated uric acid in such patients, on the one hand, it can be good because we can talk about the good response to therapy, but on the other hand, it can lead, dear colleagues, to quite serious kidney injury. Manifested uric acid levels can lead to acute kidney injury. There are three mechanisms of development, such as obstruction of the crystals of the uric acid, cytokine release syndrome, the cytokine storm, as we call it. That's what we had in patients with coronavirus. And finally, a sharp reduction in glomerular filtration rate. There are three types of tumor lysis syndrome in terms of severity. Lab TLC, when electrolyte balance is broken, and there might be clinical TLS, when electrolyte changes are accompanied by medical and clinical complications, such as acute kidney injury and also, heart arrhythmia and spontaneous TLS. That's a very rare condition. Hopefully, it can develop only in case of non-Hodgkin lymphomas of high degree and due to the quick growth of malignant tumors. So we can see that this symptom can lead to the development of the disease. At this symposium, we've been talking a lot about urate reducing therapy. The question is, maybe in this category of patients, it is necessary to start urate reducing therapy in advance, thus to prevent kidney injury if it can develop. We understand that any patient we start treatment with aggressive chemotherapy can develop acute kidney injury accompanied by increased uric acid. So the basic uric acid level is of great importance, but this study shows that due to chemotherapy and allopurinol administration, when we increase the level of uric acid, but this therapy can be rather safe. Another drug, which is quite interesting, but not used quite often as a result of lots of side effects, and it is quite toxic. It's urotoxicase. In case of TLS, urotoxicase can be used to reduce renal complications. This is an enzyme, and it catalyzes the process of oxidation of uric acid. Well, human beings and mammals do not have this enzyme, so its introduction from outside can reduce the level of uric acid quite quickly. Studies have shown that when urotoxicase is administered, the frequency rate of TLC goes down, as well as the mortality rate. There are quite a lot of patients, 471. That's a large study that showed that nevertheless, unfortunately, there is a high probability of adverse events. And of course, urotoxicase loses to allopurinol in this situation. So TLS can be characterized by elevated uric acid levels, sodium and phosphates and creatinine in blood serum due to the release from the cells that can lead to fatal arrhythmias and renal insufficiency. Dear colleagues, of course, it's a very narrow question, and I hope that this category of patients is not quite typical in our clinical practice, but in my presentation, I wanted to draw your attention, especially therapists, general practitioners, cardiologists, nephrologists, and even hematologists, that you should not forget about this condition, and you should control the uric acid level in such patients. Thank you very much. My colleagues have already tuned in, and we are ready for an interesting discussion concerning hyperuricemia in our patients. So the first question is quite interesting, and it's about the class of drugs which are gaining momentum in our clinical practice, not just in cardiology, but in nephrology as well. That's SGLT2 inhibitors. Can such drugs can be considered as a new hyperuricemic drug? The role of SGLT2. Yes, there is such an effect when the uric acid level drops when patients are on SGLT2 inhibitors, and naturally in clinical guidelines, this class of drugs is not recommended for treating hyperuricemia, but they are being used, but we need more clinical trials that would allow us to include SGLT2 in guidelines, so they lead the uric acid level, which is a good sign. And of course, they can be used as an additional treatment. So this class of drugs can be considered, but we should just pay attention to clinical indicators. Elevated uric acid is not such an indicator, but nevertheless, SGLT2 lead to a positive effect by reducing the uric acid level, and due to glucosuria, we can see an increased production of uric acid. So I think this is especially important for proximal renal canals. Thank you very much, Marina, for your answer. And indeed, when we administer specific drugs, very often our patients with cardiovascular diseases and kidney diseases usually are put on several drugs. Patients with chronic heart failure, usually they are on 4 drugs, and this class of drugs, such as SGLT2 inhibitors, can have a positive effect on reducing the level of uric acid, but empagliflozin and dapagliflozin can be administered not as hyperuremic drug, but we can just say that these drugs can have a positive effect, which is quite necessary for patients who need therapy with diuretics and who have elevated uric acid level. The next question: should we correct the dose of allopurinol for patients with liver cirrhosis? I'll probably answer this question. The use of allopurinol as any medicine, well, means additional responsibility on the part of the doctor. Tolerance to this drug, objective and subjective, blood indicators and liver indicators. It depends on the specific patient. If the patient has gout and arthritis, of course, in this case, liver cirrhosis is not a contraindication for administration of low doses of allopurinol. We should use a CHAD-PEW, clinical manifestations, liver transaminase, and treatment should be started with 50 milligrams of allopurinol, maybe once a day. We can titrate the dose, and we can achieve minimal dosage at the initial stage. If the patient has asymptomatic hyperglycemia, in this case, medical treatment can be quite effective. And if allopurinol is needed, we should administer this drug in low doses and control the liver. So again, you can see allopurinol has the right to use here. Thank you very much, Raman. And we would like to draw attention to the fact that medical therapy is good, but in any case, even if we already started our treatment, and diet is also a very important factor here in treating patients. The next question is, what should be the doses to administer allopurinol for patients with chronic kidney disease? Or we should avoid allopurinol before the nephrologist counseling. We have nephrologists here, and I think we'll get a good answer to this question. As for me, I would answer this question the following way. Well, we should not wait until nephrologist counseling. In Nizhny Novgorod, we don't have a lot of nephrologists, and if any patient with hyperuricemia is referred to a nephrologist in such situations, I think we'll just miss a lot of time. We should have a clear understanding when allopurinol can be administered and in what doses in this difficult category of patients. So who is going to answer this question? Roman, you again? Who is going to answer this question? I think that each of us can make our contribution to answering this question. I agree with you that it's not an indication to postpone therapy and to wait nephrologist counseling. because a therapist and a cardiologist can make a decision, any specialist who is going to see this clinical situation first, to see this patient first. And here I would probably say that if it's stage 3 or stage 5, the doses can be different here. And from 50 milligrams, for example, to titrate to a higher dose at stage 5, well, there are recommendations that allow the use of this drug once in 2 days. As Roman has already said, we're talking about not just cases of severe kidney insufficiency. So here you can see the clinical picture, and these patients can be candidates to administration of allopurinol, and you can see clinically it is a safe drug, but we can start with 50 milligrams. If it's stage 3A, then increase to 100 milligrams. Well, until you achieve the proper indicators. Thank you, Marina. Colleagues, any other opinions? Well, as Marina has already said, I agree with everything. Just one more remark. Patients with gout, with hyperuricemia and manifested, well, kidney pathology, if there are no cardiovascular risks in such patients, maybe we can look at mifepristone, because there are studies that it has a lesser impact on the renal function. Metabolism is different as compared to allopurinol. So this drug can be an alternative to allopurinol. Thank you very much, Evgeny. Well, I can make my comment as well. Well, I would ask the following question to the one who asked this question. Well, C3A or B, because it can be important. 45 and 55, well, is not 75 or 65. These are different levels. And I would probably refer such a patient to a nephrologist in my practice, but I would probably monitor this patient for a month or 2. If after the administration of allopurinol, there was no reduction of glomerular filtration rate, in this case, well, I would probably not send this patient to a nephrologist, but when allopurinol is administered, usually, well, glomerular filtration rate even increases. As for until it is C4, we should not just bother a nephrologist. Okay, thank you, colleagues. The next question, a man with arterial hypertension, stage 1, has gout. What, for example, sartans or the inhibitors would you administer? There is a question for a cardiologist. That means me. Well, dear colleagues, I'd like to draw attention to the fact that today we've been talking about diuretics. Diuretics is a very arguable class of drugs in terms of their use for patients with hyperuricemia. But if we're talking about RAS, well, here the situation is quite different, and we know that ACE inhibitors or sartans that can partially be used on patients with gout with caution, under control, but it's quite possible because diuretics can provoke kidney injuries, but ACE inhibitors or sartans can prevent such conditions. So in this case, the uric acid level will not be changed in such patients. When we're talking about patients with arterial hypertension, stage 1, in this case, this patient may not be in the high risk category, although the patient has gout, and I think there will be combination therapy administered, such as RAS inhibitors and RAS blockers can be quite efficient here. And we have studies of sartans. Sartans can also be used here on patients with gout. As for ACE inhibitors, well, here we're talking about the compensatory effect, and we can use this particular drug. Colleagues, maybe you have other opinions. Well, dear Natalia, just a minor addition. I agree with your response, and here we're talking about the starting therapy, or the patient may be on this therapy already. So like isinopril or any other inhibitor. In this case, if the patient is already on therapy, it should be continued. You can have a positive effect. If the patient comes to see you for the first time, we can consider such a drug as monotherapy. Losartan, a drug that can block EUAT transporter. It's not a class-specific effect, but nevertheless, if there is some basic therapy, I think the therapy should not be changed if the patient is on therapy for some time. Thank you very much for this important addition. A question for Marina. Although we're talking about the patients with lymphoproliferative diseases, but nevertheless, it's a question for a nephrologist. The patient is hospitalized with acute kidney injury requiring hemodialysis. The uric acid level is 1800. What should be the dose of allopurinol? For this patient, we need more history data. What was the reason for acute kidney injury? The level of uric acid like this was such for a long time, or we don't have enough data, or the lab indicators are not known to us. And if we're talking about this stage when we need replacement renal therapy, naturally, allopurinol should not be considered as a possible drug of choice because of the neurotoxic effect. And in this case, we assess the indicators in dynamics. We assess the uric acid level in dynamics when renal therapy is being conducted. If the patient was on allopurinol before, in this case, we should start not with allopurinol, but to consider replacement renal therapy as an option that can have an impact on all these events. To answer what dose should be used in order to treat different clinical conditions, and then we will see what the response on the part of the patient is. Thank you very much. Colleagues, we have like 4 minutes left, so we'll try to answer the next question quickly. For prophylaxis, can we administer, when we have TLC, can we administer allopurinol or rasburicase? Well, or febuxostat. Yes, the drug is registered. Yes, you can use it when the patient has TLS, and it showed better efficacy as compared to allopurinol. There were comparative studies conducted, 30 milligrams of allopurinol and rasburicase, but again, this is only in case of TLS. Well, can we combine colchicine with allopurinol and febuxostat? Well, I do not know about any studies in this field. Colleagues, what is your view? In principle, if the patient has gout, well, you should do this. You should administer this combination therapy. We should assess GFR. Colchicine can be administered to prevent seizures, and then allopurinol and febuxostat, and we administer allopurinol from 3 to 6 months. It's necessary, and they are good in combination. A young woman, 39 years old, half a year after COVID-19, had joints, knee joints, pain, no pain in joints. Well, osteoarthrosis, second, third degree, uric acid 370, 380. Should allopurinol be administered? Well, such patients are not rare, but we do not have enough information here whether she has gout or not. And if we consider the patient who might have gout, again, just on the basis of this data, it's impossible to make a diagnosis. Synovial fluid should be tested. And if we look at the uric acid, well, we should look at additional risk factors such as cardiovascular risks. So in this case, it's difficult to answer this question. The uric acid level is not that high. Well, maybe a special diet should be recommended. Well, no energy drinks, no alcohol, no seafood. And in dynamics, we can see what is going to happen. After COVID, the uric acid can also be elevated and associated with the viral infection. Thank you very much. That's an interesting question because the uric acid level in women, well, can be different. It's a borderline condition. I would like to draw attention to non-medical therapy because all our recommendations are based on what level of uric acid we should achieve. How we achieve this level, that's a different question. If the non-medical therapy is effective, why not start with non-medical therapy? What level of uric acid should we achieve if the patient has no gout, but has psoriatic arthritis and hyperuricemia? Well, colleagues, let me answer this question. We are assessing arthritis first and foremost, and we know that arthritis can lead to different comorbidities. So if we see such a patient and he has ischemic heart disease and hypertension, well, psoriasis and hyperuricemia, well, if uric acid is 600 and higher, well, I think there are no grounds to reach some particular level, like less than 360, for example, if, for example, a person has concomitant diseases. Thank you very much. Well, it looks like this question was due to the fact that you showed such horrible pictures with arthritis. Well, distinguished colleagues, we would like to thank you for your interesting questions. I would like to thank my co-presenters for their interesting presentations. We had an interesting discussion indeed, and dear colleagues, will be glad if after this symposium, you will be able to be more attentive to those patients who have borderline conditions, borderline indicators of uric acid, and to patients who have high levels of uric acid, because today my colleagues and I showed you the range of different reasons that may lead to elevated uric acid, and it's not just gout. Thank you very much and goodbye. Dear colleagues, good afternoon. I'd like to open the symposium devoted to urinary tract infections. Professor Arutunov, yesterday at the opening of the plenary session, said that the program committee has done a lot of work to formulate the agenda for today's meeting, which is going to be very interesting. So small wonder, urinary tract infections will be the subject of two symposia. One of them is in hall number 4. UTIs means we're dealing with urologists, and as for our agenda, primarily we're selecting the antibacterial drug, the duration of the therapy, and some urological or surgical manipulations to remove obstructive uropathies to reduce the recurrence. As for therapeutic issues concerning UTIs, it can be different from the urology agenda. And today I am glad to welcome Vladimir Salukov. He is not a urologist. He is a specialist in the field of endocrinology, and he will be talking today about very important issues. Several years ago, we got a new class of drugs. We encountered some concerns regarding to what extent these drugs can increase the risk of recurrence of UTIs. So today, maybe Mr. Salukov will dispel our myths and our concerns. Please, the floor is yours. Thank you very much. Professor Batyushkin, Professor Arutunov, I'd like to thank the European Association of Therapists for the invitation to participate in this very important symposium. It is of a practical nature because we're talking not about some virtual issues, but about our reality we encounter in our practice. And I hope, as far as my presentation is concerned, sometimes if we do everything all right, we encounter such patients, but we minimize the number of complications. Distinguished colleagues, I would like to talk about infectious complications of therapy with SGLT2 inhibitors and methods for their correction. I would like to start by saying that infectious complications for diabetes mellitus is not new. There are lots of different mechanisms which determine the risks, the frequency rate of infectious complications in patients with diabetes mellitus. These are mechanisms related to immunity. These are aspects related to the reduction of humoral immunity, reduction of antioxidant protection. Micro and microorganisms change their properties, their virulence, as it has been shown in some studies. Pathogens in such conditions when the patient has diabetes mellitus change their mode of action. And there is another interesting aspect, an immunological peculiarity, and a reduction of concentration of immunoglobulin A in mucus. Of course, there is a link with diabetes mellitus and infectious processes, especially when we were before the COVID-19 period. Diabetes mellitus naturally determined the frequency rate and more severe course of COVID-19, but also pay attention to the fact that as for respiratory tract, well, urinary tract infections are more common as compared to respiratory tract and soft tissues in patients with diabetes mellitus. The risk of infection is 3 times as much if a patient has diabetes mellitus as compared to those who do not have diabetes. And pneumonia takes up a very small percentage of occurrence, but here we're talking about bacterial pneumonia first and foremost. What are the mechanisms of development of urinary tract infections in patients with diabetes mellitus? Well, there is the immune dysfunction, which is a very interesting aspect. We're talking about glucosuria, and we're discussing the issues of UTIs. Well, glucosuria in patients with decompensated diabetes mellitus, as it was said before, with the loss of glycemic control. But right now, these are patients who have different conventional microorganisms such as Candida, Candida albicans, Candida glabrata, and Candida tropicalis. So this is the yeast infection which becomes dominant in the conditions of glucosuria and decompensated diabetes mellitus. Recent experimental studies have shown that Candida albicans produces protein stimulated by glucose, which is similar to complement protein receptor, and this protein predetermines the worsening of phagocytosis of the host, which does not combat Candida. In this case, adhesion of Candida to the epithelial of vagina in women takes place much faster. This is the explanation why, first and foremost, we're talking about females and why we're talking about the higher frequency of yeast infection. So there is a specific mechanism in conditions of glucosuria because this particular condition leads to the synthesis of this protein. In speaking of safety issues of SGLT2, the situation is much worse as compared to decompensated diabetes mellitus in terms of the development of this Candida infection. We understand perfectly well that the pharmacologically induced glucosuria is very persistent. This is the major condition for using SGLT2, and it is quite significant in severity. If we consider glucosuria in terms of SGLT2 co-transporter, the situation is much worse for patients with diabetes mellitus, but it is temporary, transient, and sometimes does not lead to significant glucosuria. And in this case, the excretion of glucose with urine is not quite significant as compared to blocking SGLT2. This slide shows ketoacidosis, which is quite widespread. Nevertheless, I marked the issue of amputation in yellow as well. We discussed the issue of amputation for a long time, but now we can see that amputation is quite a rare occurrence. And infections of urinary tract and genital infections, well, I pay attention to genital infections because this component, when the patient has glucosuria and diabetes mellitus, are interconnected, and it's one of the most important problems for us. And here I would like to present the classification of UTIs, which was used in different studies of SGLT2 inhibitor. According to this classification, all infections were divided into urinary tract infections and genital infections, which are not related to urinary tract. Genital infections were considered in such studies. As for UTIs, traditionally they're divided into upper and lower urinary tracts. The upper urinary tract, that's pyelonephritis, lower UTIs, cystitis, prostatitis, and you can see as for genital infections, we're talking about the two major nosologies, such as vulvovaginal candidiasis, that's the right name for this condition, and balanitis. So in this design of the study, of cardiovascular safety, there was a proactive polling related to UTIs and genital infections. So, dear colleagues, let's just divide these two types of infections, these two types of classifications. Urinary tract infections are the ones linked to affected urinary tract, starting with kidneys and urethra and prostatitis. Genital infections are those which are linked with genitals. Here we're saying that as for SGLT2 inhibitor studies, there were an increased rate of the frequency rate of genital infections. This was shown in many studies. I would like to show you a meta-analysis. More than 40,000 patients with diabetes mellitus type 2, which were analyzed in 77 clinical trials, and UTIs and genital infections were considered separately. All patients were on SGLT2 inhibitors. Urinary tract infections in most studies are those when we have one as a divider, and you can see the median here, and you can see the frequency rate of those infections, like patients with diabetes mellitus, but who were not on SGLT2 inhibitors. And you can see that this cohort was not different from those who just had diabetes mellitus, but who were not on SGLT2 infections. And you can see that SGLT2 inhibitors do not lead to an increased rate of urinary tract infections, but the risk of genital infections in such people is significantly higher. You can see this median are to the right of 1, and you can see that SGLT2 inhibitors lead to a higher rate of genital infections. And this meta-analysis showed 4 SGLT2 inhibitors. The fourth one was not like on this slide. It was empagliflozin, and we analyzed the frequency rate of genital infections depending on the drug administered to a particular patient and also gender, men and females. In most cases, you can see that primarily these were women. As far as the frequency rate of genital infections, you can see that women have a lot of genital infections, and in each study, the figures are more or less the same. So from 7 to 10% is the frequency rate among women. They had this particular complication, genital infection. When we analyzed the frequency rate of genital infections, it turned out that this infection occurs more often among women, less among men, and circumcised man practically has no such infection. So that's the distribution in terms of the frequency rate. In terms of a risk of severe UTIs in the study where sodium glucose co-transported to inhibitors and the risk for severe urinary tract infections when metformin was used, for example. And you can see there is no difference between SGLT2 inhibitors and DPP4 inhibitors. This is the study which included more than 60,000 patients. So UTI infections are not linked to genital infections. That's the condition which occurs on its own. Naturally, the researchers were concerned about the risk factors for the development of genital infections. So those 10% of women who have this kind of complication must have specific circumstances which lead to higher frequency rate of genital infections. And I would like to show you some of the data provided in this study. It turned out that it doesn't matter what age the patient has. It doesn't matter what renal function the patient has. And I can even say that the situation is even better when there is the reduced glomerular filtration rate. But smoking is of great importance. The study has shown that also the previous history of genital infections in a particular woman is of great importance. So these are the circumstances why the frequency rate of genital infections is higher among women. These data are very intriguing because it is important to interpret the data properly. Sometimes we should take into the consideration the local immunity, the immune dysfunction, and other immunological aspects as far as this phenomenon is concerned. But still, there is no conclusive explanation, but the fact is the fact. And I should say that, yes, there are genital infections that we must take into consideration. There are risks linked to this kind of infection, especially when we see patients, when we believe that the therapy can be very useful and it should be of a particular type, but we also understand that in those trials that were conducted with different molecules in different circumstances, the profile of patients was different with the different frequency rate of cardiovascular diseases, with the different duration of diabetes mellitus. Often those were studies of different duration, but in any case, whenever we're talking about the bigger or lesser frequency rate of a particular adverse event, such as the genital infection, we understand that sometimes we simplify the statistical conclusions, different cohorts of patients, and that means that sometimes we do not take into consideration some other factors, such as smoking, for example, and how it is linked to the risk of development of genital infection. For us, well, as for risk-benefit, the benefit is of strategic nature because 10% of genital infections among women, that's the maximum figure, is usually occurs in women who are on SGLT2 inhibitors. But you can see, well, metformin here, the figure is much higher, but nevertheless, metformin is still the first-line drug in terms of reducing the blood sugar level. As for dry cough, you can see the indicator is 21%. 1/4 of patients have dry cough. And at the same time, we're talking about the situation when it doesn't reduce the importance of SGLT2 inhibitors. It should be just canceled, like in case of metformin. First, you reduce the dose, and then the patient takes the drug in the evening, but nevertheless, as for SGLT2, we can see that, well, the number of MACE drops, the number of hospitalizations drops, well, terminal renal insufficiency drops, and again, you can see there can be an increase of genital infections, and as for the risk amputation, it is not proven. As for genital infections, it's plus 36 per 1,000 patients for 3.5 years of the intake of SGLT2 inhibitor. So you can see, well, the benefit is higher than the risk. So in my view, this balance is always in favor of SGLT2, and our task is to figure out to what extent those adverse effects are significant. And I would like to say that usually these are just mild or immediate adverse events, not severe adverse events that can be controlled. Our task is to inform the patient to take specific measures to prevent such adverse events. And you can see there are the guidelines with all the necessary recommendations. In this case, we can win as far as our fight against the genital infections is concerned in patients on SGLT2. And of course, we can administer local or systemic drugs that will determine the control of symptoms. So what are the recommendations for women to prevent genital candidiasis? As for the first two items, well, it's balanced diet and sound sleep, avoiding stress. It's not so easy to recommend all these things. And of course, the recommendations are good, but they sometimes cannot be observed. As for the third item, well, personal hygiene, this is very important. It works nice, and well, the change of pads and tampons on a regular basis, and even more often than on a regular basis. So this is very important as far as personal hygiene is concerned, especially after each urination. And as for the treatment tactic, I think this is the simplest and most understandable part of my presentation. Everything is quite clear here, and it has been tested on our patients all too often. The recommendations which were formulated way back in 2018 and 2016, in 2018 concerning SGLT2 and in 2016 concerning genital infection, well, these recommendations show that these are anti-mycotic drugs such as miconazole and systemic therapy with fluconazole, which is highly effective. You see it once and, well, obviously, you realize how good the drug is. And as for severe conditions or recurrence, we should turn to subspecialists depending on what the condition is. And I should say that urologists do not fall into this category. As for balanitis, well, treatment, well, of this condition does not pose any difficulty. The major problem here is to convince the patient to take the drug for a long time, because after one day, when the symptoms are gone, the patient stops the therapy, and compliance is very important. So as you can see, SGL2 inhibitors should be taken anyway, as it has already been mentioned. So SGLT2 inhibitors increase the risk of genital infections, but not UTIs. Their effects can be different depending on the class type of drug, but primarily it is due to different designs of studies, different cohorts of patients. And for us, it is important to talk about prophylaxis and prevention with our patients. And of course, when this therapy is chosen, we should take into account the family history of genital infections in a particular female. Well, prevention is effective, but when this disease occurs, it usually not severe and doesn't require any drug cancellation. This is all there is to it. Thank you for your attention. Thank you, Vladimir, for this presentation. I'm very grateful to you because as I was listening to this presentation, I think many family doctors, many therapists, now have no questions like when and how long should SGLT2 inhibitors should be administered. SGLT2 inhibitors are very widely used in clinical practice. So you talked about urinary tract infections. Well, you talked about genital infections and lower urinary tract infections, which are often bacterial in nature. I often ask the question, glucosuria or diabetes per se, if, for example, we're talking about the inherited glucosuria who have no diabetes mellitus, but there is the effect of SGLT2 and who have persistent glucosuria, they have no risk of genital infections or bacterial infections or urinary tract infections. Well, in both cases, there is glucosuria, and I think the topic of diabetes and its impact on resistance of urinary tract and genital tract, well, can be of great importance. I'm very grateful to you for this wonderful presentation. And now let's move to Alexander Arutyunov, who will be talking on a very important subject, because I do not know what the situation is with our audience, but my head is splitting about the superbugs, super infections, which are polyresistant to everything we have in our arsenal to treat our patients. And when such a patient is hospitalized to our university clinic, I should say that during his stay in the hospital, we're trying to take tough epidemiological measures. We wash the ward, we change the linen. We are afraid that this infection can colonize other patients. That is why, while the situation is very ambiguous and there should be motivations for that. Please, Professor Arutyunov, the floor is yours. Thank you very much for this introduction. I'm very grateful to you, and I will try to answer your question. So, dear colleagues, let's think about it. New antibiotics in the treatment of UTIs. Do we need new antibiotics, and how can they be classified? As it was mentioned by Mikhail Batyushkin, we are talking about two groups of people. One group of people are those with superinfection. We're talking about resistant bacterial strains. Another group of patients are those who have cystitis, well, bacteriuria, which is symptomatic, and these groups of people can overlap. We understand it perfectly well that recurrences of cystitis increases the risk of severe infection. And if this develops together with the chronic kidney disease, well, in this case, we have a more resistant patient because the patient has been treated with antibiotics many times, and now the patient poses a systemic risk for the ward in which he is located. So do we need new antibiotics, and for whom? Here is an abstract portrait of the patient, and I can just divide all infections into three categories: asymptomatic bacteriuria. It's important to talk about it, cystitis and pyelonephritis. So let's just look at these three conditions, and I will primarily talk about asymptomatic bacteriuria and cystitis without mentioning pyelonephritis in detail. Why have I decided to take this category, and why is this presentation is a follow-up, a logical follow-up to Professor Saluhov's presentation? These categories of people with diabetes mellitus are more subjected to asymptomatic bacteriuria, and let me just say who these people are. Asymptomatic bacteriuria, well, man and female. For example, as you can see it here, if Escherichia coli is present, it is more dominant. And of course, it's 10 in the second power if urine is taken through the catheter. It's important to know if just we have 10 in the fifth power in one woman, it doesn't mean that the woman has bacteria. There should be 2 tests done. Well, who are the patients in the risk group? These are patients with catheter. These are patients with who are in old people homes. These are patients with diabetes mellitus, and these are people who are over 70 years old. So these are people in the risk group for the development of asymptomatic bacteriuria. Well, we know these risk factors. Well, adenoma, well, urine incontinence, well, neuromuscular diseases, etc. But if we dig deeper as far as the subject is concerned, the answer will be quite surprising. Most people with asymptomatic bacteriuria do not have clinical advantages in terms of treatment. Moreover, the recent data have shown that asymptomatic bacteriuria can be some kind of protective mechanism from the development of more severe infections of urinary tract. The biggest study about the use of screening was done in 2008 and showed the senselessness of such a screening for asymptomatic bacteriuria. And you can see that mostly women and sometimes children were included in this study. What's new in the European guidelines? First, patients with recurrence of urogenital infections. If we try to treat such patients like there was an episode of infection, and if we try to treat them, we have patients with recurrent cystitis. And in this case, between the cystitis, we caught asymptomatic bacteriuria. If we try to treat bacteriuria, we will worsen the situation. Right now, there is a hypothesis of the symbiosis with this bacterial flora, which is protecting against other bacteria. And also there is another interesting study which is still on about the bacteria which cause the asymptomatic bacteriuria, and often these are different bacteria, different strains. Thus, we do not treat such patients. The second group are patients with diabetes mellitus type 2. There are some changes here. Asymptomatic bacteriuria often occurs more in patients with diabetes mellitus, but just one study, tried to study the link here. Why before we thought that if we get rid of bacteriuria like Escherichia coli, we'll be able to have a good effect on the progression of CKD, but it did not happen. And if there are symptoms of diabetes which are very well controlled, well, treatment is not indicated. But if we're talking about patients with uncontrolled symptoms of diabetes, it's strong. There is weak evidence that treatment should not be administered. If a diabetes person can control his symptoms, it's one thing. If the symptoms are controlled, it's another situation. There are other groups of patients like postmenopausal women. In the past, we thought that they should be treated. Now it's quite the opposite. Patients with liver transplantation, well, there are no additional risks. Patients with a permanent catheter, well, treatment is not indicated. Patients with nephrostoma, here treatment can be considered because asymptomatic bacteriuria is a risk factor for complications, but that's just one study. But before urological interventions, treatment is indicated. To sum up, I would like to use this table. Of course, there are more parameters, but I will sum up in this chart, well, treatment of bacteriuria is not indicated for women without risk factors, patients with the diabetes control, postmenopausal women, patients with destruction of urogenital tract, and patients after liver transplantation. 1A is the level of evidence. Treatment of asymptomatic bacteriuria worsens the prognosis, especially in patients with recurrences, and treatment of bacteriuria is indicated before urological surgery. Let's look at cystitis. Yes, we'll be talking about pyelonephritis later, but I don't have much time about it. As for cystitis, here we have new schemes of treatment. A lot has been said about them. And as for these new regimens, they allow us to choose the optimal approach to treating such patients. But here we have a very difficult question. It boils down to the growing resistance. Like, for example, trimethoprim can be used if resistance does not exceed 10% according to the guidelines. Unfortunately, it doesn't happen all too often in real clinical practice. Cephalosporins, there is a growing resistance to cephalosporins because cephalosporins are very widely used globally. Plus, there are also limitations concerning glomerular filtration rate, which complicates the patient management. In speaking about cystitis, it would be wrong not to mention about the reasons of recurrent cystitis. And we identify, well, a lack of we identify multiple sexual intercourse, well, the use of spermicides, regular change of the sexual partner, the presence of the urogenital infections among mother, and also, well, infections in childhood. In the postmenopausal women, again, you can see urogenital infections before the menopause, urinary incontinence, also catheterization in older women, well, not observance of personal hygiene. We understand that when we have such a woman with diabetes mellitus, sometimes it's very difficult to observe personal hygiene. And also a very small volume of urine, daily urine, well, because Escherichia coli has, well, a special flagellum, and, well, of course, a small amount of volume cannot wash it off. For that, we need a bigger urine volume. Here we have two questions. First and foremost, and there was a presentation before that, the use of SGLT2 inhibitors is growing. They increase the risks of urogenital tract, and there is also the growing resistance of bacteria to the existing antibiotics. And here you can see some of the publications, but there are more publications like that. We can see growing resistance of bacteria to existing antibiotics, especially Escherichia coli. It depends on the region. We cannot use the European data and apply them to Russia or vice versa. Even within Russia, the resistance can be different. A patient who was in the intensive therapy unit will have one flora. A patient in the urological department who was on catheter will encounter more resistant flora as compared to those patients who were treated at home, but there are no new antibiotics. And as for non-complicated urinary tract infections, over the last 20 years, we just saw one new antibiotic. Over the last 20 years, imagine that. So what's new? What kind of antibiotic is this? This is triazoxanthirthiline, and as you can see here, the studies were stopped due to the high efficacy. Triazoxanthirthiline was the first antibiotic of topoisomerase type 2 inhibitor, which is very similar as respiratory fluoroquinolone. fluoroquinolones, but when, well, the mode of action is the same as fluoroquinolones, well, DNA topoisomerase 4 and DNA gyrase bind to DNA during replication, but when we start comparing it with levofloxacin, we can see that when there is the group which is resistant to levofloxacin, here we can achieve much better effects in terms of this patient treatment. Escherichia coli can be fully eliminated. If we look at Staphylococcus aureus, or E. coli or pneumococcus, well, of course, we need high doses for pneumococcal infection, but even here we can see the high efficacy of this drug to achieve the elimination of the bacteria, depending on the cause of infection. Again, you can see the data here. As for E. coli, well, it is very widespread. If a patient has CKD, that's a critical question. Antibiotics have an effect on glomerular filtration rate. If a patient has a CKD, will this drug be working on such patients? Well, let's look at previous antibiotics, aminoglycosides. Well, aminopenicillins are not recommended for patients when there is high resistance and have toxicity. When patients have urinary tract infection, well, again, you can see, well, aminopenicillins are used very rarely. Ciprofloxacin has limitations. Well, the 12-hour dose should not exceed 500 milligrams if CKD is from 30 to 50, and the 18-hour dose should not increase to 500 micrograms if glomerular filtration rate is 5 to 30 milliliters per minute. Macrolides are not always used for urinary tract infections. And again, respiratory fluoroquinolones, the daily dose should be reduced by a factor of 2 if glomerular filtration rate is less than 50, and by 4 times if it's less than 20. Well, so how does this drug behave itself? We can see the cutoff, which is 30 in terms of GFR. Again, you can see the data of 2021. The study was finished in November 2022. Up to 30, for example, we're talking about GFR. There might be problems with clearance, but patients who have GFR 30 and up, there are no problems. Will this drug be approved right now? Well, it will be probably approved for patients with GFR less than 30, probably, and down until 15 milliliters per minute. Our task is as follows. I raised this topic because we have more antibiotic resistance, and we should not just use the same antibiotics again and again. Again, we can see that I have shown you these slides because more and more patients with chronic diseases, patients who are in post-menopause, patients with diabetes mellitus who have heart failure, these are people who have a high risk of asymptomatic bacteriuria. Often, this category of patients can develop cystitis, and this bacteria, due to poor local immunity, can lead to progression. We understand it perfectly well that due to antibiotic resistance, bacterial invasion can progress. That is why the appearance of new antibiotic can be used even when GFR is low in this difficult category of patients, can be a salvage therapy for the first time over the last 20 years, when we do not just go back to old antibiotics, but we use a new drug that can eliminate the pathogen in the urinary tract. It's safe, for kidneys. It is effective in terms of infection elimination. It's not approved even in Europe, but it is still at the stage of approval. But very soon we will have a new instrument, and our goal at this conference is to look into the future. We're going to have a new instrument, a new class of antibiotic. Over the last 20 years, we can use it effectively in our category of patients. So I primarily focus on elderly patients. For them, this drug will be more efficient. Our goal is to stop developing pyelonephritis. If a patient had the severe pyelonephritis with scars, this is a guarantee that the chronic kidney disease will progress, because fibrosis will destroy the kidney. So our task, and this will be the theme of our next presentation, is to see the link between urinary tract infections and chronic kidney disease. Thank you very much. And I'm giving the floor to Mikhail Batyushkin. Thank you very much for this wonderful presentation. Just the recent data of the European Association of Urologists, they came up with a new document, a very thick document, and now we have hope that in the future we can get an instrument to fight super resistant strains, super infections, so that our patients could get proper treatment. Dear colleagues, let's move on as far as our agenda is concerned. And Alexander Rotunov raised this question in his presentation. UTI and CKD, there is a link. We're not talking about cystitis here, but we're talking about the infection when it is in the lumen and without getting into the mucus, without causing clinical manifestations. Can this infection cause CKD or not? Alexander Rotunov basically gave an answer to this question, especially when the infection is asymptomatic. It cannot cause cystitis, but in some situations when the patient has obstructive uropathies or patients with lower urinary tract prolapse, well, maybe these patients, need such infections, but then the patient comes and says, the therapist doesn't treat us, but there are bacteria, there are 3 crosses, and indeed, we can see quite a significant colonization of E. coli 10 in the 6th power. Well, this is infection, but it has no clinical manifestations. Naturally, this infection doesn't need treatment. And also, when microorganisms are in the urinary tract, well, the organism sees this infection and maintains the local protection at a specific level, thus preventing the development of true urinary tract infections with mucous inflammation. So if you do not want to turn the patient with recurrent cystitis or uveitis, well, you should not treat asymptomatic UTIs, but when there are UTIs with clinical manifestations. And well, Alexander did not talk about pyelonephritis. I'll talk about pyelonephritis more. Can pyelonephritis be the reason for chronic kidney disease? And well, Hippocrates in the 4th century before Christ said that that's one more kidney disease, severe pain. Well, pain can be very severe, and there is swelling near the spinal column. Well, maybe there is purulent pyelonephritis. Hippocrates said that there should be a cut made in the swelling area in order to drain the pus. Well, he did not call it pyelonephritis, but at least, Hippocrates was one of the first who described this condition, but Pierre Ryan was the first one who introduced this term, pyelonephritis. There is the Atlas of Diseases. Well, pyelonephritis was hyphenated, pyela plus nephritis. It's basically the infection which penetrates into the renal tissue and forms nephritis. So I should say that this concept of pyelonephritis means acute inflammatory process. Chronic pyelonephritis is the condition which does not in fact exist. We discarded this term. Those who still use this concept, they use ICD-10, International Classification of Diseases 10. There is such a concept of chronic pyelonephritis, but the 10th review was formed more than 40 years old. When I was a small child, they developed ICD-10. And I remember very well that in those years, there was the concept of chronic pneumonia, which was later discarded. And what we are having today, we have acute pneumonia, but we do not say it is acute. So we have pneumonia as an acute pathological process accompanied by inflammatory changes of the lung tissue in the alveolar space of the lung tissue. And the same is true if you look at European or American guidelines, national recommendations as well. You won't see the term chronic pyelonephritis. You will see just the term pyelonephritis. Since it's acute, why should we write that it is acute? So the inflammatory process means the contact of the micro and microorganism. There should be the interaction between these two types of organisms, and microorganisms should be expelled from macroorganisms. E. coli, well, can live in the large intestine during the UTIs or without UTIs, and can be hematogenic, non-hematogenic. And when there is the lower urine tract infection, pyelonephritis or cystitis, well, so there can be different options. But when we treat UTIs, well, we expel E. coli from the urinary space. It goes back into the abdomen. In this case, well, it's theoretically possible, but specific conditions should be developed. So when this thing occurs, when E. coli gets into the urinary tract, well, it happens in specific situations of persistent reduction of properties of macroorganisms, especially when microorganisms have more aggressive properties. That's what patients think about. But once, well, I had counseling, and they thought that, well, there should be an antibiotic that can just eliminate E. coli. We cannot just eliminate E. coli. We can just return it back to the abdomen from the urinary tract. And it's true of specific microorganisms. For example, when the urinary bladder had Pseudomonas aeruginosa, how can we remove Pseudomonas aeruginosa from the bladder? It feels quite well on the surface. It covers itself with a bacterial film. It becomes, well, basically inaccessible for antibacterial drugs. And Of course, in this case, no matter what antibiotic you use, bacteriophages or anything else, it would be difficult to oust this infection. So in some cases, we're talking about lowering the protective properties of microorganisms. And on the one hand, we can make this contacts easier. Well, acute pyelonephritis develop in this case, but not in all patients. It's not a very widespread disease. And also the situation when this pyelonephritis becomes recurrent. So there is a series of acute episodes in one and the same patient. For that, we must have a clear understanding that there are general conditions for microorganisms when the protective properties are lowered, and there are local processes. Urodynamics is very poor. So you can see that it looks like, as far as this patient is concerned, there are problems with the tub or pelvis, and you can see there may be some compression. Well, sometimes we can see it's not quite enough to cover the lumen of the ureter, and you can see that it can cause the spastic reaction of the ureter in this area. For such patients, well, there might be recurrences of UTIs. Nephrectosis can also occur, but it's not enough to trigger this process. In general, when we have this poor resistance of microorganisms to different infections, there might be specific risk factors which determine the universal risk factors, such as non-modifying and modifying. Age, for example, recurrent pyelonephritis occur more often in elderly patients. Well, male, gender, well, usually, well, such a condition occurs in men after 60 due to hyperplasia of the gland. In women, it can occur in young age. The start of the sexual life is a risk factor for such urinary tract infections. I'll talk about this later. While answering your question, I already saw such a question in the chat, and we'll have a chance to answer it in detail. In the first presentation, it was mentioned that hyperglycemia and diabetes mellitus are linked to glucosuria, can have an impact on genital infections. Plus, there are some other factors. As for vegans, vegetarians have several factors associated with their health. For example, often iron deficiency anemia can develop because plant products usually have, well, ferrous, but not ferric acid. And also the risk infection can be high here because, well, there is a lot of alkali in plant food. Well, urine becomes alkaline, and E. coli and Klebsiella feel quite well in such an environment, and especially when they live in the intestine. There are also studies regarding the use of berries such as cranberry, etc. Such products, well, are not the main treatment of infection, but they can be used in addition to the main treatment. In this case, we can acidify the urine. There are some other factors shown here. For example, arterial hypertension, hyperleukemia, well, also hyperuricemia, and you can see there is the infectious process that leads to tubular intestinal nephritis, and you can see toxicity due to endogenic reasons. Of course, these factors can potentiate one another. Also, well, there may be other problems, like some patients say, I feel, well, my salts break. And of course, these factors are interrelated. Well, chronic insufficiency, hypoxia, well, when the tissue is not very well blood supplied. So these are the factors leading to CKD and to the development of the infection in the renal tissue. Well, rab rats, in order to cause pyelonephritis, well, we can just remove one of the branches of the renal artery to create the situation of hypoxia. And in this case, well, this condition develops. In this case, well, usually the rat has a severe protection system, so they ligate the renal artery in a rat, and also this leads to infection. The same is true of people. Obesity is another factor of progression into CKD. A fat person is usually the one who has different bacterial and fungal infection, which occur due to mechanical reasons as well, because there are faults and, well, other problems to mention, but a few. If proteinuria occurs and CKD, this is an independent risk factor of progression of CKD. Cytokines produced by the cells of tubular epithelium, if they're affected by infection like pyelonephritis, affects, for example, tubulars, and of course, the tubular epithelium, in response to the damage, can throw different pro-inflammatory factors, bringing together macrophages, neutrophils, leukocytes, well, local factors of response, messenger sites, in order to counter the infection. And this counteraction can be quite effective in terms of the efforts taken by the entire cellular space of the renal tissue, but the same pro-inflammatory factors have an impact on the renal tissue, on fibroblasts, for example, on collagen formation. Well, metalloproteinase can be activated, and this particular space, when some microorganisms are removed, well, for the time being, the inflammatory process occurs. There is the reparation process, collagen formation takes place, and there can be tubular interstitial fibrosis, and this is the foundation of chronic pathology. And Alexander Arutyan showed how nephrosclerosis can occur after pyelonephritis. This is the chronic kidney disease. Often it can result in replacement renal therapy. So the question is, all those recurrent pyelonephritis, are these the processes independent of one another? Can we just bring them together into interstitial fibrosis, or is it a chronic turbointerstitial nephritis, which includes acute episodes of pyelonephritis together with the reparation of renal tissue? This is an important question. Chronic pyelonephritis doesn't exist as a concept, but tubular interstitial nephritis as a concept still exists. Well, Chronic pneumonia does not exist anymore. We discarded this term. Like, we know that pneumonia can lead to pneumofibrosis and especially post-COVID-19 complications. Well, prove that. Nevertheless, we discarded the term chronic pneumonia, but chronic tubular interstitial nephritis still exists. Although the processes are universal, there are some episodes related to pyelonephritis, but in between, what do we have? The chronic inflammation. No, we have tubular interstitial fibrosis. Between two pyelonephritis, there is no inflammation, but there is a reparation process. In the pure sense, there is no infiltration, inflammatory infiltration. There are no lymphocytes. There is just fibroma formation. That's the third stage of any inflammatory process. That is why this is a rhetorical question. Well, we should probably discard this definition, but what we called chronic pyelonephritis in the past, today we call it chronic tubular interstitial nephritis of the inflammatory genesis. What does it look like in real life? Well, for example, we can talk about the interstitial nephritis of non-infectious genesis. Well, half a year later, the patient has pain in the back, acute interstitial nephritis. Half a year later, there is another episode of the back pain, and these episodes naturally reflect, well, the situation in the tubular interstitial space. From episode to episode, the level of nephritis increases, the disease progresses. Well, you can see, well, one acute pyelonephritis can, as a consequences, cause tubular interstitial fibrosis, just like any other kidney disease, like DILI. And this process, if there is no pyelonephritis, can be self-maintained as a result of the formation of internal cascades, such as atrial fibrillation, for example, etc. And you can see different pro-inflammatory molecules which were clinically studied that confirmed their impact on the risk and progression of tubular interstitial fibrosis. So chronic pyelonephritis is the term which was used in the previous century, or tubular interstitial nephritis of infectious genesis is the type of tubular interstitial kidney injury in the form of recurrent inflammatory process. Not always tubular interstitial nephritis, well, can occur with pyelitis. Pyelitis not always take place together with the tubular interstitial nephritis. Thank God, sometimes there are such situations. Not all pathogen can cause pyelitis, but it can cause, well, interstitial nephritis, well, such as COVID-19 virus or flu virus can lead to this. Let's look at the international database. Pyelonephritis, for example, how do different, sources treat it? Like the American data on PubMed, I entered pyelonephritis, and I got a lot of references to this term where chronic pyelonephritis was used. But when I looked at these terms, these were non-English speaking publications. Usually these are Russian speaking publications translated into English, and those who lived in the Soviet Union. And again, there is no such a term as chronic pyelonephritis. Well, again, you won't find this term chronic pyelonephritis, and if you see it, usually it is applicable to studies in Russia or the CIS countries. Well, so there may be 1 or 2 episodes of pyelonephritis. These acute episodes may not lead to recurrence all too often, but nevertheless, there is tubular interstitial fibrosis which progresses. Why does it progress? There are no episodes of pyelonephritis. There is no infectious agent. Why this process progresses? First of all, the nephrons that can exist on its own reduce in number in the scars, like 5, 7, or 10% of nephrons can be killed. So the remaining nephrons are in the state of hyperfiltration. So the patient has oligonephrony because he has less number of nephrons as compared to the real situation. There is an overburden of proximal tubulars, and the proximal tubulars, as soon as the burden increases, they start producing pro-inflammatory, pro-fibrotic factors that lead to the fibrosis of interstitia. Any burden on them, inflammatory, non-inflammatory, lead to the cytokine disturbance. Well, the reparation process starts, that's the third stage of any inflammatory process, and they start participating in the reparation process. Well, the endothelium of proximal tubulars, well, realizes that there is an impact on the remaining nephrons, which are lesser in number. And here we can see that TGF-beta is produced, and metalloproteinase are being produced in large amount. Well, also monocytic protein is being produced, and macrophages are being produced, and so on and so forth. There is a kind of vicious circle formed. The epithelium of proximal tubulars, well, gets a signal, and there is the realization that it should participate in this battle. I should be in the interstitial space. The epithelial cell is being changed into the mesenchymal cell, the neofibroblast, and it gets off the basal membrane, which it was linked with, and there were intercellular contacts. Now this cell penetrates into the fibroblast, and it goes into the interstitial space and starts producing collagen. Well, it produces stimulators, but they are also turned into cells migrating into the interstitial space, thus leading to the fibrosis of this space. This leads to total collagenization of the interstitial matrix, and those nephrons which died off, well, cannot be revived, and this cascade leads to a significant progression of the tubular interstitial fibrosis. So that's why RAS blockers are used as SGLT2 inhibitors and SADs and corticoid receptors and so on and so forth. These are the drugs which activate live nephrons. They stop the process of hyperfiltration. They lead to the reparation of the proximal renal epithelium in order to extinguish this process, to break this vicious circle, which constantly leads to the formation of new and new collagens. It leads to the revascularization, and as a result of it, we can see that hypoxia occurs, especially of the capillary bed. Fibroblasts in conditions of hypoxia begins to produce collagen type 1, not type 4, which is kind of softer, which provides a better permeability of interstitial space for oxygen and other molecules, but of type 1, which is more solid, and this closes this vicious circle leading to fibrosis. Here are some of the examples of our patients. Well, you can see folded tubular, and you can see this blue space, that's fibroblasts, lymphocytes. So these are extracapillary matrix, and you can see there is a lesser amount of this matrix here, but nevertheless, we can see fibrosis here. So this is the renal tissue subjected to fibrosis, the proximal epithelium of tumula. You can see the granular epithelium. Some do not have the nucleus. Well, you can see also the damage to the pedicetus cells. Such cells can produce a lot of pro-inflammatory factors. Well, chronic tubular interstitial nephritis is a series of episodes of acute renal injury, such as pyelonephritis, like acute pyelonephritis, or DILI, tubular interstitial nephrosis, is a self-progressing pathological process, and acceleration occurs when there is a new episode of pyelonephritis. The mechanism of development is the progression of fibrosis. Pyelonephritis, in other words, is always an acute process, but it's important whether it's one episode or several episodes, and they can lead to irreversible tubular interstitial fibrosis that can lead to CKD, and this is the basis of CKD for such patients. Here you can see the variants of CKD in case of relapse. Who said that pyelonephritis leads to CKD? Maybe there was a CKD of a different genesis before pyelonephritis. CKD, well, can lead to the infectious genesis in frequent relapses of pyelonephritis. Well, when we have back pain, we can use non-steroidal drugs, and of course, these issues are very important. Dear colleagues, I would like to thank you for your attention, and let's open the chat and answer the questions together with Alexander Arutyunov. The first question is, do you think that circumcision, and I mentioned this in my presentation because we have therapists, nephrologists here, maybe some therapists who do not know what it is. Well, can circumcision be the only way out for continuous of SGLT2 inhibitor therapy? When it's a man, well, when he has a lot of recurrences, but SGLT2 is already administered. Alexander, what's your view here? It can be the only way out sometimes, but it's just one of the options in patients with recurrent infections and there were studies that, especially when we're talking about fungal infections, well, the frequency rate of fungal infections can be reduced here, but that's not the only way out. It's just one of the options. So for some men, you preserve the chance to preserve part of the penis, right? And there are different attitudes towards the circumcision. Those people who do this for religious reasons, such as Muslims or the Judists, well, in this case, recurrent UTIs are of lesser occurrence. The second question, do you consider the use of SGLT2 inhibitors in patients with nephrostoma or cystostoma? Let me start answering this question. Yes, of course, we consider that. SGLT2 inhibitors can be administered to such patients that have indications for SGLT2 indicators. In this case, this inhibitor could be administered unless there are recurrences of fungal infection. Then SGLT2 inhibitor will be discontinued. Well, Alexander, what is your opinion? I totally agree with you. I think here we are talking about a bridge to the next question. Well, do you manage patients on SGLT2 therapy together with gynecologists and urologists? Well, yes, it's possible, but I think this is a must. I agree with you, Alexander, in terms of gynecology and urology. Let me just emphasize this for general practitioners. Alexander said that if there are recurrences, we should turn to gynecologists and urologists, because a family doctor, for example, sees a patient with infection, you have the right to treat this infection until it becomes a headache and leads to constant relapses. How can we strengthen local protective mechanisms of the urinary tract, especially when there are non-specific cystitis in young women? When we're talking about the ulcer of the duodenum. All right. So I will start answering this question. Sure. For me, Alexander, I don't know about you, but for me, well, we have a lot of patients like that who, like young ladies, 14, 15 years old, as soon as the debut of sexual life begins, if she has the hidden problem in lower, urinary tract, this problem manifests itself. It can be cystitis or anything else, so you should refer such a young lady to a urologist or a gynecologist. Sometimes urologists do not pay attention to anatomical peculiarities, but urethra can be open on the frontal wall of the vagina. Well, these two holes must be anatomically far away from each other. If they are close, you should do the plasty. We just cut the mucus sideways, and before each coitus, you should take an antibacterial drug, but you cannot just live like that all your life. But I know patients who are quite calm here. They use, precoital prophylaxis. Those who like sex very much, they prefer, the plasty. So everything depends on your opportunities, on your needs as far as sexual life is concerned. Alexander, anything on your side? Yes, I could say, as far as those last recommendations are concerned, well, there was an interesting analysis concerning the evidence base of what can be used if we do not consider plasty. Well, in this case, you can drink a lot of liquid. Do not try to keep the urine for a long time, but those recommendations do not have a high level of evidence. Well, like when we were talking about some berries and some particular food, but estrogen replacement therapy in menopausal women has a higher level of evidence. Also, prevention, which is used for women with immunodeficiency, and basically also personal hygiene. Well, these are the major things that should be taken into account. We don't have a magic wand that could solve this problem once and for all. Most of the items don't have a high level of evidence. Thank you. So here is another question. Partially, you answered this question. Asymptomatic bacteriuria in pregnant women, do we need to treat it? And if cystitis occurs, a woman goes for a PCR, and well, then atiotropic therapy with local drugs of the sexual partner or not? Do you agree with this tactic? Well, bacterioscopy can be done and then treatment. Well, bacteriology and further treatment. Of course, if there is some pathology detected, both partners should be treated, but that's not very relevant for bacterial infections. Well, that's important for candidiasis or other diseases or for fungal infections. But if we're talking about E. coli, what kind of prevention can you use here? If the partner has no E. coli, then what? Well, so do not scare your sexual partner, right? Yes. Just have several just miss several intercourses while you get rid of this infection, and your sexual partner will desire even more after you missed several intercourses. And during this period, you can just get rid of E. coli. Well, this question, we have already answered it. Here is another question. Proteinuria in young patients. What is the tactic? Do we need therapy? Well, is it persistent proteinuria or one-time proteinuria due to fever, or when you were on the bus, or when you were running on the stadium? Well, there's a proteinuria due to physical efforts. If it's persistent proteinuria, of course, you should identify the cause of it and refer the patient to a nephrologist. Sometimes protein is 0.3 grams, and 3 years the patient is on hemodialysis. In this case, we should identify the reasons and start treatment as soon as possible. Well, calcituria without bacteria, what should be the approach? Well, the bacterial tests were done twice. Well, there is leukoturia, and there is no inflammatory process such as cystitis, urethritis. Well, it's kind of asymptomatic. What should be done in this case? Asymptomatic, well, symptomatic should be treated for sure. Asymptomatic, well, in 60% of cases, you'll identify a microbe causing this infection. So it's not an argument. If there is an infection and there are indications for treatment like cystitis, well, it should be treated. But leukocyturia, you can be eosinophiluria. Well, order a test in your lab. If you don't know what to do, order the leukocyte morphology. It's a simple test. Any lab technician can do it. And if you identify leukocytes and eosinophiles here, maybe the patient suffers from lupus, maybe metamizome sodium was administered to this patient, and this led, that means toxic nephritis that doesn't require bacterial therapy. What is the name of the new antibiotic? I forgot this name. Okay. There are some other questions. What should be done with asymptomatic bacteriuria to prevent infectious endocarditis in patients with a high risk of infectious endocarditis? Well, frankly speaking, I don't think there is any prophylaxis possible. It's hard for me to imagine how asymptomatic bacteriuria can lead to infectious endocarditis. Now, of course, I can imagine it. We can come up with some hypothetic story about the immune deficiency patient, but we remember that if we plan any intervention, asymptomatic bacteriuria should be treated. In other cases, well, we cannot imagine this translocation of the bacteria from the urinary tract to endocardium. At least it's difficult for me. Well, also, is treatment necessary before cabbage? Well, no. If, for example, there's abscess, yes, treatment is needed. If there is hematoma, yes, well, intravenous drug abuse, yes, but not before cabbage. Well, all right. So that's the answer. And the last two questions. Pyelonephritis, how to make the diagnosis, and fosfomycin, can it be administered for women? You're right, chronic tubular nephritis of the infectious genesis. Well, like 10 in the fifth power active phase, and it can lead to recurrences, but you may not mention this. It's not interesting for us as far as diagnosis concerns. Fosfomycin, well, can be used if it's effective clinically, microbiologically. Usually, well, it should not be canceled. Keep using the drug while it is effective. That's my opinion. Do you agree? Yes, I agree with that. Nothing to add here. And it looks like we answered all the questions. So you will finish. No, you will finish. You're the moderator. Dear colleagues, I'm very glad that we had a chance to discuss this topic, urinary tract infections. We have a very good therapeutic company, endocrinologist, internists, therapist, cardiologist. We discussed these problems. When we have urologists, usually everything leads to stone disease, to the administration of antibiotics, to resistance. But here we covered very important therapeutic problems, and that why we had this particular agenda today. I hope that in the future, the Eurasian Association of Therapists will discuss different issues related to UTIs. I'd like to thank my colleagues for these wonderful presentations. I hope they will broaden your horizon concerning recurrent UTIs. Thank you very much. And I would like to say that we had more than 500 people online listening to us. I'm very glad that this topic raised so many attention. C-reactive protein, can it be an indicator for starting treatment of asymptomatic bacteria? No. Even if it's a high sensitive C-reactive protein, well, and it is elevated, find the background inflammation. For example, in patients with cardiological profile, find the source of infection. Your attitude to Euravaxone in chronic infections, it's positive. Yes, Euravaxone, I have a positive attitude. It is mentioned in European and American guidelines. Yes, you can take it per os 3 months. Well, if it's effective, it's good. Good luck. If it's not effective, try it once, then just cancel it. Well, plant Eurosceptics. My attitude is very negative because they're often used as the main therapy in manifested infections, and this leads to exacerbations and plant nephropathies, allergic reactions to different plants and herbs, no evidence base. And even if there is a nice drug containing Eurosceptics, please be very careful. Well, asymptomatic bacteriuria, should it be a concomitant diagnosis? If we're talking about the risk category, well, probably formally we can do it. All right, so we can treat it and monitor such condition. Yes, naturally cure and monitor at least. If it's just a find, I wouldn't do it because, well, treatment doesn't require any monitoring. All right, I agree. Dear colleagues, that's it. Thank you very much. See you at next breakout sessions. Bye-bye.